It is my pleasure to introduce our next speaker that's going to round out our series here, Dr. Leslie Delfiner. I'm sorry, did I say that wrong, Dr. Delfiner? There we go. She is the co-director of the MDA Care Center at Montefiore and an associate professor in the Division of Child Neurology. Dr. Delfiner is a child neurologist with subspecialty training in neuromuscular and electrodiagnostic medicine. A graduate of Cornell University, she received postgraduate residency training in pediatrics at the Mount Sinai School of Medicine in New York City. As co-director of the MDA Care Center at Montefiore, Dr. Delfiner cares for children and adults affected by all forms of neuromuscular disease. She also cares for patients in Montefiore's Myasthenia Gravis clinic, and she is committed to providing patient and family-centered care in a supportive environment. She is experienced in the management of refractory myasthenia gravis and congenital myasthenic syndrome. Dr. Delfiner has a special interest in building individualized support systems for children with myasthenia, from coordinating school safety plans to helping children understand and cope with their condition. Dr. Delfiner, thank you so much for being here today. We are very excited to hear from you, and I will turn the time over to you now.
Thank you so very much. Good evening, everyone. Again, my name is Leslie Delfiner. I'm a pediatric neurologist who has the joy and pleasure of getting to work with families affected by all forms of muscle and nerve disease, but especially enjoy working with children and families who are impacted by disorders of the neuromuscular junction. Today, we're going to walk through some complicated topics together and try and highlight how we can build patient-centered care around a rare disorder that maybe some other providers and physicians in a child's life, like their pediatrician, may not have experienced before. How can we create safe, comfortable care that doesn't get in the way of life? We'll talk about what the neuromuscular junction is. We'll talk about the different types of myasthenia in children, both the more commonly discussed autoimmune forms and the rarer genetic subtypes. We'll talk about how to coordinate the care team, how to engage different family supports, and then we'll go through some key resources. At the most basic level, myasthenia and congenital myasthenic syndromes, as you all know at this point, is an issue with how the nerve communicates with the muscle. We rely on reliable transmission, a signal coming through the nerve ending to be released upon to the muscle cell so that the muscle cell squeezes. And when that relationship and that communication is unreliable or inconsistent, weakness emerges. That's the basis for all types of neuromuscular junction disorders. That can be anything from myasthenia to congenital myasthenic syndrome to Lambert-Eaton syndrome to botulism. When communication through the neuromuscular junction fails, weakness emerges. Myasthenia, in the most classic form, the autoimmune type, is caused by an antibody that is blocking the normal communication, so that sometimes the signal from the nerve can get through to the muscle, and other times the signal cannot. And that's why we have characteristic fluctuating weakness that comes and goes, worsens and improves, and may change throughout the course of the day. Children are not just small adults. This is what you will hear pediatricians say throughout residency and training and becoming their first professional jobs. You'll hear us say to ourselves as we are becoming clinicians, children are not small adults. We have to learn how to take care of children differently because our framework changes. First, when we talk about neuromuscular junction disorders in children, is it the plain autoimmune type that we hear about in adults? Or is it something else? Is it something inherent to the child that may run in the family, even if nobody else has had symptoms before? When we're talking about the autoimmune type, it's juvenile myasthenia gravis. And just like in adults, it can be ocular, meaning that the only muscles involved are the muscles of the eyes, or generalized, meaning that it's affecting muscles of the eyes plus other muscles, or not very much in the eyes and other muscles in the body. They are not two separate disorders. They are not two separate problems. More than 50% of patients may present with ocular myasthenia that then goes on to generalize. There's some patients and some people and families who describe symptoms that were very much generalized at first, and as symptoms become controlled by medications or over time trend towards improvement, sometimes the symptoms can become predominantly ocular, even though we know that that person is impacted by generalized disease. Words can become incredibly confusing because we use them in different categories. So we talk about ocular versus generalized, and seropositive, meaning that there's a blood test showing an antibody, or seronegative. And we talk about age of onset. Was it before puberty, or was it at the time of puberty or after? And you can choose to characterize your myasthenia in any of these ways. So a child with an autoimmune problem could have ocular disease that is seropositive, meaning an antibody test is positive in the blood, which could be one of the many different types of antibodies. Or somebody could be seronegative and either ocular or generalized, and so on. There's a reason that myasthenia is identified as a snowflake disease, that each patient is individual and unique, both on paper and in practice. That doesn't mean that there isn't a guiding sense, a guiding light, and a direction based on community experience and evidence-based research. But when coming to the neurologist's office with your child, the plan that you will hear will be unique to your child's situation and will be adapted based on the literature and evidence we have to guide myasthenia care. But the specific plan is going to depend on your kiddo. Just like in adults, there are different antibodies that can be tested for. Unlike adults, no matter what your symptoms are, the overall likelihood of the antibodies being positive is just lower in children. And so we may have to do multiple rounds of testing before antibodies become positive, or they may never become positive at all in some cases. I'd like you to take a pause for a moment and talk about the other type of myasthenic syndrome. Myasthenia means weakness. While autoimmune or juvenile myasthenia gravis is more commonly known, more commonly discussed, and more commonly seen in practice, there is a group of problems, a group of disorders that are actually genetic problems of the neuromuscular junction. We call these the congenital myasthenic syndromes. If we go back to that original slide with all of these blurry words, each little colorful image here is a piece of the neuromuscular junction. It's a protein that has a role in keeping the muscle and nerve communicating with each other normally. And each of those proteins is coded by a different gene. When a gene is not functioning normally due to a change in the gene, it can cause dysfunction or a disorder. And so in the congenital myasthenic syndromes, one of many different identified genes can be impacted and not functioning correctly. And so somewhere in that pathway of communication, there's dysfunction. So one little piece may be missing or not working correctly, and so that message from the nerve to the muscle is no longer reliably transmitted. There is a growing list of genes known to cause different forms of congenital myasthenic syndrome. What was once thought to be an exceedingly rare group of disorders is becoming more commonly known. Often children with this disorder will have weakness or symptoms such as the ptosis, eyelid drooping, fatigability, trouble with feeding or breathing early in life. And so we think of that when children are presenting very, very early on, especially in infancy. But there are some cases that are picked up later, and you may hear your neurologist talk to you about sending genetic testing for this if the blood work for your child has not shown an antibody and there's not a convincing history that it's the autoimmune type of myasthenia. Genetic testing is performed either through cheek swabs, saliva collection, or blood tests, and there are a variety of complicated benefits and risks to consider on the basis of the information you could gain, even though it's only a blood sample or a saliva sample. But this is something that you may hear your neurologist talk about if the stars line up to suggest it may be a possibility. I'd like to pause for a moment and talk a little bit about what does genetic mean. When you look at the list of conditions that the MDA partners to serve and support, most of the disorders seen within the MDA community are genetic. We don't automatically think of myasthenia in that way. But this subtype of myasthenic disorder is genetic. Genes are the invisible pieces of material that live inside of our bodies and our cells, and each gene has a unique role to play and an instruction to provide the body. A gene is responsible for making a protein that is important in the body's work. There are more than 20,000 genes that we know of in the human body. With 20,000 genes in the body, it's impossible to think that any one family lineage wouldn't have some issue with one of their genes. And so genetic problems are never anyone's fault. We have no control over our genes as human beings. There's nothing positive or negative that we have done to control them. Sometimes genetic issues arise after many generations when a disorder is passed on by a combination of a gene change seen from two parents. Other times it's passed down from generation to generation in what we call a dominant fashion, where people are affected in each generation. And other times something is a change just within a child as a unique individual during the process of that person being created as a human in development. And we call that de novo, meaning a brand new change. But again, this is not caused by anyone doing something right or wrong. We have no control over our genes. Finding out about a congenital myasthenic syndrome has significant implications and importance for the family in general. This could mean identifying other people in the family who may be affected by the same problem but had never been diagnosed or identified before. It can help us guide our care better for that specific person, and we'll come back to that in a moment. And also it can inform a family about what it means for having future children. What is the likelihood or the probability for a given gene change for it to occur again in a future pregnancy, either for a child's parents, for the child themselves, or for other family members who could unknowingly carry the change. Working closely with your neurologist and a genetics team can help provide families with knowledge, awareness, and comfort so that the information you have is usable and understandable, and you can use it to help your family and your child. But let's go back for a moment. Let's go back into our categories of autoimmune, meaning juvenile myasthenia gravis, and the genetic congenital myasthenic syndromes. What does this look like in a child when you come to a neurologist for the first time? Diagnosis can be based on history and examination, blood testing, nerve testing in the form of repetitive nerve stimulation, and chest imaging. Let's go through each of those briefly. Children aren't little adults, and children certainly do not describe their symptoms in the way that adults might. And so many of you who are joining us here today may have experienced the frustration of not being able to fully understand what your child was describing. Maybe their physicians had trouble, because children may not tell you that they have double vision. They may say that it's blurry. They might not tell you that they have weakness in their bodies. They may just say that they're tired. And so patience and certain kindness to ourselves as parents and family members and supporters and clinicians to take the time and understand what the symptom really is and let the child share with us in the best way that they can what they're experiencing. Physical examination may also look quite different in a pediatric patient than in an adult. We may be doing squats where we pick up stickers off of the floor repeatedly to see how many times we can stand up before we get tired. We may be running up and down a hallway. We may be going into the hallway and climbing the stairs. Maybe we'll be looking at funny pictures that are taped up on the ceiling to see if our eyes can remain in an upward position without the eyelids coming down. As much as this sounds like fun and games, it's a functional way for us to assess how a child is doing. And once your child has been diagnosed, those fun and games become a reliable way of checking in on a child both in the office and at home. You and your clinician will come up with questions that are useful to ask for your family member. So if things such as brushing the teeth and brushing the hair or washing hair in the shower are notoriously signs of weakness in your child, that'll be a signal that you'll check in on every time you come into the office. How's bath time going? Is she able to do it on her own, or have you been having to help her? These are the types of things we might talk about in a very functional way that isn't less meaningful than the more formalized examination and history questions we might ask in adults. Blood testing is important in diagnosis because the antibodies may guide us in the right direction and can help solidify a diagnosis. EMG, in the form of a repetitive nerve stimulation test, is when we check for how the signal is reliably moving from the nerve to the muscle. It is a procedure that can be, in some situations, done with sedation, other times not. Even though it is not the most comfortable experience in the world, it is brief, only done when necessary, and most tolerated without much of an issue. And finally, chest imaging. When we read about the experience of myasthenia gravis, we know that thymoma, which is a tumor within the chest linked to onset of myasthenia, is well reported and known to be somewhat common in the adult population. Maybe about 15% of people who have myasthenia will have a thymoma. Thymoma is rare in children. We do still image the chest of children diagnosed with this condition because of those very rare cases. But timing and choice of imaging, which is often a CAT scan of the chest, but in some cases an MRI with contrast dye, is pursued after planning for safe imaging procedures, just to make sure that a thymoma is not sitting there, even though it is very unlikely in children. Treatment options depend on the patient. Pyridostigmine, also known as Mestinon, is a medication that makes you feel better. If reliable communication from the nerve to the muscle depends on a chemical called acetylcholine moving through that space between the nerve and the muscle and landing on a receptor on the muscle to make it squeeze, Mestinon helps people feel better and helps people be stronger by allowing that acetylcholine to remain in that space for a longer period of time. And so that at any given moment, more of that chemical is available to land on whatever receptors may be available and open. And so you can understand that Mestinon makes things work a little bit better, but it does not treat the underlying problem. The underlying problem in myasthenia gravis is an autoimmune dysfunction, an antibody-driven process, even if we can't find proof of those antibodies. And so we use medications such as steroids and steroid-sparing agents to try and tone down and modify the actual cause, the root of the dysfunction causing the myasthenic symptoms. This is really important for us to think about for a moment. Steroid medications are effective. They have to be started slowly and under the careful guidance of your neurologist or your ophthalmologist, depending on the scenario, because steroids, when they're started, can actually make symptoms worse and kind of trigger a significant worsening before you see the improvement. And so we as a community tend to go slow and low at the beginning with careful guidance to families on what to look out for. There's some situations where we do not worry about that as much, and there's some situations where we're using other medicines that reduce that chance, so we can go perhaps a little bit quicker. But generally, steroids are started slowly. Steroids in a young child have the same side effects as in adults, but sometimes amplified. Because steroids impact growth, bone health, raise risk for things like diabetes and high blood pressure, can impact the way that children act and behave by making them a little bit hyperactive, and of course can increase risk of developing infections. We are cautious with the use of steroids in children and do our best to reduce the dose as soon as safely able in a slow, steady manner to let the body adapt, as steroids can't be stopped suddenly once your body is used to them. and often will need to be replaced with a steroid-sparing agent. Depending on your child's scenario, the severity of the symptoms, and response to initial therapy, a steroid-sparing agent may be necessary. Treatment in children evolves over time, often based on our experience in the adult population. And so you may have heard about these wonderful new medications that we have that really look at a disease-specific approach to myasthenia. Medications called the anti-complement agents, things like eculizumab, that block the inflammatory response at the neuromuscular junction and have been found to be quite effective in many adults who are seropositive, meaning that they have the antibody and generalized. And medications called neonatal FcRn inhibitors, which are agents that essentially help your body break down immunoglobulins, which are the same type of protein structure that an antibody is. These are medicines that have been shown to be effective in the adult myasthenia population in certain subsets. At this time, some of these are in early work in the pediatric population, meaning that there are clinical trials that are ongoing. There are situations where your neurologist may talk to you about what we call off-label use about one of these medications if it were accessible to you, but there is no standard use or standard plan for these at this time. This is one of the reasons that having a close and trusting relationship with your neurologist is important, because if a child were to potentially benefit from one of those medications, it would be based on your child's specific situation and not something that's going to be dictated by a protocol or an algorithm. We do know that there are enrolling trials for pediatric patients. We have the benefit of the MDA Clinical Trials Finder, which I'm sure the team will be able to put a link to in the chat here. The MDA Clinical Trials Finder helps you register your information so that the MDA does the work of checking online through the registered clinicaltrials.gov website for any enrolling opportunities for potential clinical trial options for your child, perhaps for a medication like one of the ones I just mentioned, to see how effective and safe they are in pediatric patients. Some loving families feel excited about the opportunities of clinical trials. Other loving families feel that they are not comfortable with proceeding with something like that. And other families say, hey, we're actually doing pretty well. Why would we even consider? And all of those things are okay. But it's great to know that the MDA has resources and tools to make it a little bit easier for you to prepare for your visits with your neurologist, so you can ask about trials if you're interested. Thymectomy, removal of the thymus gland, generally through minimally invasive means, is known to be beneficial in the adult population for those who have acetylcholine receptor antibodies and generalized disease. There are some situations where we do use thymectomy when somebody's blood tests are negative or when their disease is ocular, but there's less research and evidence to back that up. Over time, we are gaining support that thymectomy is likely beneficial in children as well. But again, we are extrapolating, we are drawing from the adult experience and our growing experience in the pediatric world. And so the decision to pursue a thymectomy is an individualized one. Any child found to have a thymoma will be urged to have a thymectomy. But there are certainly cases, more and more often, where children with generalized disease or refractory disease that's been hard to treat, who have antibodies, and less commonly not, may be offered a thymectomy. Whew. Congenital myasthenic syndrome. Diagnosis depends on history, examination, genetic testing, and often an EMG. Coming to a diagnosis of a congenital myasthenic syndrome can be often an arduous and long process. And having the ability to speak openly with your neurologist about what you're experiencing can help make this a little bit easier. The treatments are going to depend on the specific child and the specific gene change. Depending on which gene is affected and where the problem in the neuromuscular junction is, there's some patients and families who will be positively affected by pyridostigmine, some that can use oral albuterol, not the puffer that we use for asthma, but an actual eaten oral version, or another medication called 3,4-diaminopyridine. There are also very rare forms of this condition that can actually respond to other seemingly confusing medicines, such as fluoxetine, which is Prozac, and it depends on your child's specific gene change. Appropriate global supportive care is crucial. Children with congenital myasthenic syndrome may have weakness in their swallowing, may have weakness in their breathing, or they may not, but partnering with a speech and language pathologist and a pulmonologist can be crucial. Working together with a gastroenterologist if feeding is an issue, and the pediatrician to build a unified care team can help children impacted by CMS thrive. People with congenital myasthenic syndromes do not benefit from medications such as steroids, steroid-sparing agents, or IVIG. Adapting to a new diagnosis. Anytime somebody's child is diagnosed with a condition, even though that child is the same person they were when they walked into the examination room 20 minutes ago, the world feels like it shifts, and that's understandable. We like to think of the care team as being centered around the family. And who needs to be involved? It's going to depend on each child, but generally speaking, the neurologist and ophthalmologist are key players on the team. The pediatrician who cares for the child in the community is so very important. The school nurse, the educators, camp counselors, who are spending daytime hours with your children and helping them thrive in their educational settings or their camp settings or their social settings. And then whatever other child-specific supports exist in your realm. But it's not really a spoken wheel model. It's all integrated. We best serve families when we aren't operating in a vacuum. And so if family is not working with the neurologist and then telling the pediatrician what the neurologist said and then trying to remember and explain to the school team and the school nurse, we all work together. And by creating clear lines of communication, we can help keep families comfortable, children safe, and disease management less burdensome. Not to minimize how hard the adjustment is, but to see that there's a path forward and a unified way for us all working together. There are resources at your fingertips that can help you getting used to a new diagnosis and identifying what type of tools are going to help your child thrive. After registering with the MDA, you have access to the MDA Resource Center. You can go online and submit a request. I have an example of the form here. You can call in for the number. But in addition to working with the social worker in your MDA Care Center, working with your neurologist directly in the MDA Care Center, if you have questions about community resources that may not have been mentioned to you or an opportunity to connect, it's great that you can reach out to the MDA and request either information through the Resource Center or even engage through MDA Connect, an opportunity to have a face-to-face 30-minute virtual call with one of the representatives who's here to support your family. School planning. Accommodations are every child's right because accommodations help children thrive. And just as we would not take away eyeglasses from someone who needs glasses to read, or some extra help with reading or mathematics from a child who needs a little boost so that they can shine, accommodations in the school setting help children with myasthenia feel good about themselves, continue to love school, and be able to participate in a way that isn't limited. This can include things like a 504 plan, giving somebody with myasthenia the opportunity to go to the nurse's office and rest if needed, offering adaptive gym or PE if that's something that would help the child, allowing for a person to make up missed schoolwork without any form of judgment or punishment or difficulty if they need to miss work so that they can be at home for their IVIG infusions or go to see their doctor. There are also accesses to services through an IEP if needed or appropriate. Preparing for these types of discussions with the school can be challenging, but resources on the MDA website, which I'll share with you, Discussions with your care provider and the social worker within your center can help you think of the types of tools that may be useful, helpful, and deserved for your child. FMLA forms, Family Medical Leave Act forms for parents, can be useful as well, so that you can miss work or reschedule work shifts as needed without fear of punishment or losing your job, so that you can bring your child to your care appointments. I'm going to be sharing in a moment some educational resources for teachers and school support teams that may be hidden from plain view from the school's perspective, but are at your fingertips as members of the MDA community. Before we move on to that, I do want to mention the social aspects of myasthenia. Children develop over time and experience the ebbs and flows of the complex social network that is elementary school, middle school, and then high school. And as they transition to becoming young adults, the goal I know that we all have for our children is to be happy, healthy, comfortable, safe, and confident. Ptosis, or eyelid droop, eye misalignment, the appearance of weakness can be challenging things for children to adapt to. Using the resources available within your school team can help your child adjust and help your child feel ready to engage fully and to let themselves shine in the classroom, even if they're going through a difficult period. Opportunities to engage with the MDA through virtual camp, in-person summer camp, the muscle walk, where kids have a chance to get together and young adults have a chance to get together, can be a huge boon as well, and has been one of the joys that I've had as an MDA care team member, getting to see how happy camp makes kids. I think you'll understand what I mean once you start up. It's helpful for the children, it's helpful for families. The MDA website has a variety of information and resources that are useful for you to use when helping to prepare for visits, to think of questions to ask, and to provide informational materials to the school team. At our center, we do provide safety letters and emergency care letters that go to the school nurse. And in that packet, we also provide a series of pieces of information provided by the MDA, including the Teacher's Guide to Neuromuscular Disease. This is a booklet that is generalized, and so not everything in this booklet applies to children with disorders of the neuromuscular junction. But your clinician and your care team can help you identify pieces that are relevant. It has useful information about things such as 504 plans, adapting the classroom environment, allowing for adjustments to things like the length of the workday or building in rest periods if needed, and for children with things like congenital myasthenic syndromes, appropriate approaches to physical therapy. There are informational pages available for the congenital myasthenic syndromes as well. You will see that other trusted organizations such as the MGFA, Myasthenia Gravis Foundation of America, also have nice laid out information available for both CMS and autoimmune myasthenia. But I will say that the MDA has done a really nice job of creating these printable resources to share with your school teams, your camp teams, and pediatricians. Safety planning. Sending your child out into the world to spend their day at school or at camp or out with their friends is a part of parenting that is potentially nerve-wracking even without myasthenia. We send our children to school knowing that they'll receive an excellent education and hopefully will have a good day. But there are things we can do to make sure that the school team is ready to take care of your child in the best way possible and to help you feel safe and secure. This can include awareness letters. It's similar to the emergency card that the MDA has created, but 5-year-olds and 10-year-olds don't carry wallets. And so we've created letters that provide similar guidance and similar encouragement and information on how to contact a child's neurologist that can be kept at the school in the nurse's office that families will have a copy of as well. We provide safety information about medications. This means two things. One, information about the medications to avoid in myasthenia list. As you may have heard in some of the other talks, there's a list of medications that are known to sometimes trigger or bring out symptoms of myasthenia or even cause significantly worsening weakness. This does not mean that we withhold treatment from children with myasthenia. Having myasthenia does not mean do not treat. However, whenever possible, we make efforts to try and select medications for treating children with other issues like an ear infection or strep throat. We try to choose medications that are not problematic and are well tolerated. Again, there may be certain situations that come up where risks and benefits of a medication need to be weighed, and we would never withhold treatment of an important medical condition. But whenever possible, we educate families on the benefit of choosing medications that are well tolerated, as long as it is an adequate, appropriate, and good choice for whatever important medical condition is at hand. In non-emergency situations, these are things that can always be discussed between the prescribing doctor who's seeing your child and the neurologist. But it's important to know about ahead of time. Your neurologist will guide specifically how that medication list applies to your child. And please understand when we're having this discussion here together that the statements that I'm making are a general statement about overall how we think of these things, but exactly how this should apply to your child is something you should discuss with your neurologist. If your child is on prednisone or another steroid and has been on it for some time, we know that there are certain concerns about stopping it abruptly, which could trigger what we call an adrenal insufficiency or an adrenal crisis, where the body is not making its own natural steroids and can trigger certain sickness, low blood pressure, and other problems. Or if a child became suddenly sick, they may need a boost of steroids to prevent an adrenal crisis from happening. If that's a risk for your child, it is well preparable. It is something that we can provide safety counseling, safety plans, and prevention plans on. Your neurologist can walk you through this, or if needed, connect you to an endocrinologist. This is the type of issue that we plan for so that it doesn't become a problem. It is not to be scary. It is not to intimidate anyone, but to think proactively about dealing with issues and thinking ahead to prevent problems. And finally, reasons to seek attention. We guide families to come in to the emergency room for difficulty breathing or swallowing, or significant body weakness, things like having difficulty lifting the head up off the bed or being remarkably weak compared to usual. Your medication and safety awareness letters will also provide guidance to the school on reasons that they should be bringing your child for attention or calling you. Here's an example of that emergency room card. I believe it was actually referred to in the last talk that we heard from one of my colleagues. This is a picture of it. The information in our safety letter is very, very similar. But again, children don't carry wallets. So integrating myasthenia into life. Doctor's appointments, perhaps infusion appointments for things like IVIG or plasma exchange, or having to go and see a variety of subspecialists like the ophthalmologist can take up time and can be overwhelming. But once we're in a routine and you've established a care plan with your neurologist, life certainly still is beautiful. This is a set of images from the MDA summer camp because I'm a huge believer in its benefits and its joy. But I know that children are in the environment having this much fun and engaging and living their lives year-round, not only during their week of MDA camp. Thank you.
Thank you so much, Dr. Delfiner. We really appreciate your time, and that was a great presentation. And thank you also for sharing so many of our resources. We appreciate that. But we do have a couple of questions, and just a reminder that if anybody has a question, to please feel free to put it into the chat, and we will do our best to get to it. But let me just get the questions we have pulled up here, and then we will go. All right, so first question for you. somebody had shared when they registered, they put this question in, what should we do in case of a myasthenic crisis in my child, and how can we best prepare for such an event?
Okay, great. Hopefully we had addressed some of that in our preparedness section there. And I'd just like to reemphasize, having information available to the people who are taking care of your child is really important. So if your child is cared for by a nanny or a daycare or is in a school setting, they should have information readily available about what they should look out for and the signs that they should call you to say, hey, something's a little off, versus the signs they should call you and say, hey, we think your child needs immediate care. That way, one, your child is safe and in hands of people who are aware of their diagnosis, because there is no shame in myasthenia. This is a disorder that we can all talk about openly, and with open sharing of information with the people responsible for your children directly, we're making sure that they're able to be at school safely and that you're able to go to work or be at home or do whatever you're doing while having your mind feel settled, that your kids are in good hands with people who know what to do. When a child with myasthenia is experiencing true crisis, true difficulty breathing or swallowing, you may not be able to come to your neurologist's emergency room at the center you're cared for. You may be too far away. Your emergency care letter should be accessible in a way that when you walk into the emergency room, wherever you end up, you can say, I have myasthenia gravis. I believe I'm experiencing signs of an exacerbation, or if you're having trouble breathing of crisis, here is information about me and here's how to reach my neurologist. I realize that not every center is going to function similarly. And if emergency care letters aren't something that are being updated frequently, that isn't necessarily wrong, because there may be other systems in place. That may be a checklist of who to call when you're sick and what to say in the emergency room. It may be a sheet that you're given to keep track of correct contact information of who to call. Safety looks different in different situations and comes in so many different forms. What is most important is that you know how to access the people on your care team should a question come up, and how to go to the right place and what to say should you have emergency signs of crisis.
Oh, thank you. Being prepared is, we often hear from adults anyways with MG that sometimes emergency room doctors, or they don't necessarily know MG. So I think that's great advice to just really be prepared and have them kind of have something ready to share on the spot about MG. Some other questions that have come in. Are there any lifestyle changes or activities that need to be avoided to minimize exacerbation of my child's symptoms?
A lot of that is going to depend on preference, type of symptom, and extent of symptom. I have had dear patients who stopped playing baseball because it was just too frustrating for that little bit of double vision coming and going when trying to bat. And baseball wasn't fun anymore. So we found something else to do. Children and young adults change their passions and interests so frequently at baseline. That's why so many of us have garages filled with random sporting equipment from the 1 or 2 times our kids decided that they were going to be a professional lacrosse player and then never picked up a lacrosse stick again.
True.
It's only reasonable and fair for us to expect that perhaps their experience with myasthenia may change what they're interested in. I will say that if an activity is provoking symptoms, that activity should probably be modified. But most activities can be modified in a way that they're still enjoyable and safe. A few hard and fast rules that I do have: activities such as swimming should only be done when you are strong, only in a lifeguarded setting, and only when somebody is also kind of watching you to notice that there's an issue. And activities where you could get seriously injured if your weakness kicked in. So deciding to rock climb without a belay probably isn't a great idea if your arms and legs are weak. And so safety is going to be an individualized issue. but many activities can be modified to be enjoyable and safe.
Yeah, absolutely. I was curious because I know some of your background has been around helping kids kind of be able to cope with the diagnosis, understand the diagnosis. Do you have any advice that you might give to a parent of a newly diagnosed child of how to approach talking about the diagnosis with them? You know, what to say, how much detail to go into?
Kids are smart and know when something is off. I encourage families not to make things secretive because that can be scary for children. And I know that parents know their individual child best. And one parent is going to know their one child far better than anybody else is going to know that child. But knowing that people are talking about things that you don't understand can be very frightening and intimidating and almost give the message that something isn't okay to be openly discussed and maybe is something not to be sharing with others. And so one, I do really recommend being able to talk about this in an office setting with your child present. I often use tools with kids to help them understand by trying to create real life examples. And so for young kids who like sports, I talk about baseball. That when a nerve needs to talk to a muscle, it's like a pitcher throwing a ball into a catcher's mitt. And with myasthenia, something's blocking that catcher's mitt. So even though your body's really doing its best to just throwing that ball and the catcher is ready to catch it, something's getting in the way and it's not your fault. And we're going to try and give you medicines to make you feel better. We also like to talk about how every kid needs to see doctors and for something. Every kid needs help with something because otherwise there wouldn't be teachers and doctors. We wouldn't have jobs because we're here to help. And just like there might be some kids in your class who wear glasses or have hearing aids or go to the nurse for diabetes medicine or may have other things, this is something you're coming to see me for as a doctor, and I'm really happy to be able to help you. And asking parents to help engage in that rhetoric and say that this is something we're doing to make life better so that it's seen as a positive and a proactive thing, even though it's not always an easy sell, especially in the teenage group where things can be a little more isolating and the physical issues with myasthenia can be upsetting. It usually helps us move forward. I'll also say that in the adult population, we know that people with myasthenia can be impacted with things like anxiety, depression, mood issues, and difficulty adapting. And that carries over to the pediatric population as well. Being open and honest with your pediatrician, your neurologist, the social worker you're working with about any issues with that you see arising is really important because we can help with that as well. Connecting families to appropriate mental health supports. We have something called Quality Impact in Life at our institution where we have a multimodal team who help engage with families to deal with the coping process. These are things that we can help with too, even though it might not say it on our business card, that that's a part of the care that we're involved in. And so I encourage you to reach out and bring those issues up.
Thank you. I love the idea of an analogy that relates to the developmental and understanding level of the child. And you just have such a lovely bedside manner, Dr. Delfiner. So thank you very much. I don't see any other questions coming in the chat, but I wanted to thank you so much for being here with us tonight. And sharing so many great insights and expertise from your own experiences as a physician. So thank you so much, Dr. Delfiner.
Thank you for having me.
All right. Well, thank you all for being here tonight. If you are new to MDA and have been diagnosed with a neuromuscular disease, or if you are a loved one of someone who's diagnosed, we do encourage you to stay engaged with us. You can do this by visiting mda.org/join and completing a short form. Joining's free. It will keep you up to date on the latest research, the educational programs and supports that MDA offers. We also wanted to just let you know that we have ongoing webinars. I did mention we're going to be talking about nutrition for neuromuscular disease in July. So that is on our website. You can register for that. We also have several next step seminars. These are small group learning opportunities for youth that are transitioning from pediatric to adult care. We also have sessions for newly diagnosed kids and their parents and newly diagnosed adults. So encourage you to check those out, especially if you are going through any of those big life transitions. We also are going to be in person in several cities this year and encourage you, if you're in the local area or nearby, to come. Those are free as well. And then we always have our on-demand webinars available. We did record all of the presentations from today and yesterday, and those will be available in the next few weeks. We will send an email with the links to all of the presentations. MDA would also like to thank again our program supporters, Alexian, Argenix, Genentech, and UCB for supporting today's virtual learning series. We would not be able to provide these programs without their generous support. We would love to hear your comments about today's program. Once you leave the session here, a webpage will automatically pop up with a short survey about today's presentations. Completing the survey provides us with really important insights to help us plan for our future education programs. If anyone has questions after this webinar, if you're looking for resources, feel free to contact our resource center at 1-833-ASK-MDA1 or emailing resourcecenter@mda.org. Thank you again to our presenters today, Dr. Rosenfeld and Dr. Delfiner, as well as our presenters yesterday. This concludes the Myasthenia Gravis learning series, and we hope to see you again soon.